He is probably the world's leading expert on Charles Bonnet syndrome. This is the mysterious hallucinations that are experienced by very many people with sight loss. So to get on with this talk straight away, I'm going to introduce and welcome and thank from the bottom of my heart, Dr. Dominic ffytche. Dominic, over to you.
Thank you, Kathy. Now I'm going to try and share my screen because that's a good starting point. Right, there we go. So hopefully you can all see that. So I've given many Macular Society talks over the years, but never before have I presented slides. It's a bit of a radical departure for myself, and I think also it's a new thing for the Society as well. And what I just wanted to say that you can listen to the talk without struggling to look at your screen, because I realize some of you here today won't be able to see it particularly very well, and I'll tell you what's there. But for those of you that can see a screen, it's the first time I've been able to show you my Charles Bonnet holiday snaps, if you like. So it's quite nice to be able to show you some of the images that I normally give at other talks as well. And the other thing to say is, I'm afraid there is an Ocado delivery expected at any point during this talk. So if you hear bells in the background, that's not a hallucination. That is Mr. Ocado arriving with the deliveries. So I'm going to start by just defining what I mean by Charles Bonnet syndrome. And for those of you looking at the screen, I've got a Venn diagram there. And one of the circles shows all the different causes that you can have of a visual hallucination. Now, hallucination is, I'm sure you're all aware, but just to formally say what it is, it's seeing something in the world around you that isn't actually there. And there are actually lots of different causes of visual hallucinations. And one of them is eye disease. And it's that intersection of eye disease and visual hallucinations. So in other words, visual hallucinations caused by eye disease that we call the Charles Bonnet syndrome. I have on the screen now, for those of you, you can see 3 portraits of the man himself. And they're taken at different ages of his life. The one that's missing, of course, is him as a child. And that's quite an important one because he starts off as something of a child prodigy. So he was known I think by the age of 16 across Europe for his meticulous work on insects and botany. And he was corresponding with learned societies everywhere. And he carried on in this vein for basically the first half of his career. At some point in his 30s, he began to struggle using a microscope. And we don't quite know why. But he describes in his diaries how he was getting headaches and aberrations looking down the microscope. And so he turns to a different area of research. He turns to what I suppose today we would call psychology or even philosophy. Now I have here the particular work of importance to us today that he wrote in 1760. And it's the analytical essay on the faculties of, in direct translation, the soul. He lived all his life in Geneva, so he writes all his works in French here. Now, if you were to read it today, you'd recognize it as a treatise really on how the brain works. And he's developing a grand theory of how nerve cells in the brain produce all our thoughts, and ultimately he's a staunch Calvinist. He's a very religious man, and he's hoping to explain how the brain can understand religion and ultimately God. But in the work, he's starting at a very basic level, describing how we experience different senses, particularly vision. And he comes up with a theory that light falls upon the eye, on the retina, and the signals are passed along the visual pathways. He doesn't know about electrical signals along nerve fibers in those days. He thinks of it as vibrations. And he comes up with the idea that there are in your brain particular nerve fibers that will vibrate when you see the color red, and a different set of nerve fibers that will vibrate when you see an object, and so on and so forth. Now, of course, he's sitting in his armchair coming up with this theory with no real evidence. So the evidence that he provides is in a case description. And I'm showing it here on the page. Please don't struggle to read it, but I'm just going to paraphrase the important bit here. So he says, I'd like to tell you that I know a respectable man full of health and candor and judgment and memory, who, when fully awake and independently of everything in front of him, sees from time to time figures of men, women, birds, voitures. Now, those of you who are fluent in French will realize that voiture is car, but of course this is 1760. So it's not cars, it's carriages. And he sees buildings as well. Now, he doesn't describe in this particular treatise who this mystery man is, but we find out later that it's his grandfather, a man called Charles Lulin, who was a magistrate in Geneva. And from Lulin's diaries, we know a little bit more about what happened to him. So he has cataract operations in about 1753, first of all in his left eye. And we don't quite know what type of operation that would have been. So it might be a modern type of operation that you would have today. Well, not quite as modern as today, but it might have been an old-fashioned couching procedure where a needle would have been poked in his eye to push the cataract out of the way. But whatever the operation, we know that it worked, because afterwards he was able to read with glasses again for a couple of years when his vision in both eyes deteriorates. That in his left eye by 1757, he can't see anything. And his right eye, the description is in his diary that he can't see what he's reading. So when he looks at the page directly, he can't see the letters, but he can see everything around the edge in the periphery. So many of you listening will recognize that he has some kind of macular problem that's developed after his cataract operations. And then in 1758, he develops his hallucinations from about February to September. And he is visited every day by Bonnet, who is making notes and asking him to dictate the hallucinations. And Bonnet then publishes his essay in 1760, and Lulin dies in 1761 at the ripe old age of 92, fully competent in any way. He has no problems with memory, as we've said, and with happy memories of his hallucinations. So in a little bit more detail, what did he hallucinate? So Lulin described seeing the figures, as we've heard, but he describes them in beautiful yellow silk costumes. Now, just as a note here, because we'll talk about this later, for him, these costumes would have been absolutely contemporary. This is the sort of thing that would have been normal for people to wear in that time. But as you'll see, people with Charles Bonnet syndrome, and there may be many of you listening today who see similar types of figures, even though, of course, this is not contemporary. What was strange about the figures was that they were wearing on their heads a casket or an inverted table. So something funny going on in their heads. Down in the bottom left-hand corner, if you can see it, he described something like a spinning jenny, a Swiss weaving machine, and he could see the intricate whirling of all the components going on, giant pigeons, pictures on the wall in gold frames of landscapes and biblical themes, I think he talked about. And then the carriage, I've got up here a carriage. And the next slide, for those of you that can see it, this is the actual road where Lulin lived. I've been to Geneva to track him down, and I found the street where he lived. He lives in a first floor apartment, so the view he has from his window is from a slightly higher up perspective. But the reason I'm showing it is because he describes the carriages coming down this lane, growing to the size of the building. And the building he's talking about, for those of you that can see my pointer, is this one here on the left. So imagine the carriage has grown to this giant proportion of the building that you can see here. And then if you look down the end of the road, there's a fountain. It looks like a pillar here. I've got it in a larger view here. So this is the fountain. And what Lulin describes is a series of hooded figures, cloaked hooded figures, coming out of this fountain and crossing his field of view to one of the side streets. Now, apart from these complex hallucinations, these objects and people, he also has very regular, or the most common thing, I suppose, that he sees are simple hallucinations. And he talks about a handkerchief, a blue handkerchief with yellow golden discs in each of the corners. Brickwork patterns, clover patterns that cover his bed, his furniture, the walls, and lots of little dot patterns, so swirling snowstorms, and very simple shapes, blue shapes, and rectangles and circles on an orange background. Now, this description given by Lulin was honoured in the 1930s by calling the syndrome Charles Bonnet syndrome, and we come across it in eye clinics everywhere across the world today. And in this slide, I'm going to show you the top 10 Charles Bonnet syndrome hallucinations. So almost everyone with Charles Bonnet gets these simple shapes, lines, coloured blobs. Most people get some form of geometrical pattern, be that brickwork or lattice work. It's got different names. One thing that wasn't seen by Lulin was a disembodied face. So someone with Charles Bonnet syndrome will describe seeing just the head looming up in front of them. And very often the features are distorted in some way. So they might be very prominent or twisted. So it's got the overall appearance of a gargoyle or grotesque type of face. Then we got the famous figures. And like I said, they're often in costume. It's not necessarily 18th century costumes. It could well be knights in shining armor or roundheads and cavaliers, and there's often something strange on their heads, a funny hat or a bonnet or an aristocratic wig, for example. Text and letter strings. Now, when you look at this from afar, it looks like a proper word or a proper sentence. But when you try to read it, you can't see, it doesn't make any sense, or it's actually not real letters. And there's a musical notation version where you see crochets and quavers and staves. And for those of those people that can read music, they say, well, actually, it doesn't make any musical sense. We've got the snowstorm particles. And right at the bottom here, about a fifth of people see vehicles. So it's not the carriages so much today, but it could be buses or trams, sometimes prams and trains, that sort of thing. So how common is this? Well, we know that around 10 to 20% of people with moderate visual loss. So if you're going to the high street optician or your eye doctor, if you can see about halfway down the chart, then that's enough to start giving you Charles Bonnet syndrome hallucinations. So I should say that more clearly. If you can only see halfway down the chart, you're at risk of having Charles Bonnet syndrome hallucinations. And if the vision loss is much worse, so you can't see anything, can't even see the top letter or just about see the top letter, maybe it's up to half of you will have Charles Bonnet syndrome hallucinations. Now, if we look at Kathy's most recent numbers, so for macular disease alone, and so that includes the older age-related macular degeneration and the younger forms as well. If we say there's about 700,000 people in the UK with macular disease, that gives us a rough estimate of between 70,000 and 420,000 people with Charles Bonnet syndrome, but that's just for macular disease. So it can occur with any eye disease. You can add in all the people that have cataracts that haven't been treated yet, all the people with glaucoma that's progressing, all of the people with diabetic eye disease, and you can imagine how all the numbers will rapidly increase beyond this. So there's an awful lot of people out there with Charles Bonnet syndrome. Now, I'm going to say a little bit about the typical sort of experience of Charles-Bonnet syndrome. And I'm going to dwell on this a little bit because I'm going to come back to it later, as you'll see when we talk about treatment. So how often do they occur and how long do they last? So I've got here a 24-hour clock, if you like, and the little rectangles indicate when the hallucinations are occurring. They're lasting about a minute or a few seconds typically, and they'll usually occur in the evening. So actually, as it turns out, around this time of the day as you're listening to me. So that is perhaps the most common form, but we can also have very commonly much more severe, if you like, Charles-Bonnet syndrome, where the hallucinations are basically happening pretty much throughout the day. And there are a small number of people who have absolutely continuous hallucinations. So this is throughout their waking hours. From the moment they wake up to the moment they go to sleep, they'll be having a hallucination. We don't have hallucinations during dreaming, so not when you're asleep, but it's certainly there the whole day. And then how long does all this go on for? Well, I've got on the image here, if you can see it, a line when you start to have your visual loss. So that's really for someone that's got, for example, wet macular degeneration and have a sudden hemorrhage and a sudden loss of vision. But for many people, there's not a sudden loss. It's a sort of gradual decline in vision. And what we're saying here is when it reaches a certain stage, that's when the hallucinations begin. And they tend to start off very severe. They don't start the next day. They usually start a few weeks later, and they will be there continuously or very often for the first few weeks or months, and then they'll gradually get shorter and you'll have fewer and fewer episodes. And we used to say, when I started working in this area, like 20 or 30 years ago, that, oh, well, the hallucinations will go by about 18 months. But in 2012, we did a survey with the Macular Society. I'm just showing the results here, but I don't try to interpret this graph. But it showed that most people, at least 75% of people with Charles-Bonnet syndrome, had already had hallucinations for more than 5 years. So obviously, the 18-month idea was not true. But this isn't to say that the hallucinations go on in this very severe form forever. For most of these people, the hallucinations have become infrequent. So you're having them maybe once a month or so, but you still have them. So it's not really fair to say that the Charles-Bonnet syndrome has gone away. And it's also true to say that the Charles-Bonnet syndrome might come back later, particularly if your eye disease gets worse, or if you develop other problems like urinary tract infections or physical problems that we'll talk about a bit later. I'm just going to have a sip of water here. Now, we're going to talk a little bit about the emotional impact of Charles-Bonnet syndrome. This is an important consideration. Around 2/3 of people with Charles-Bonnet syndrome don't really mind having it. It's not something that they worry about. They see it as part of their day-to-day life and part of their visual loss. About 10% positively enjoy having visual hallucinations. And the reason why they enjoy it is because they can see them in better detail than their real vision. And it's sort of a reminder for them of what it used to be like to see. And it's really only 1/3 of people where the Charles-Bonnet syndrome becomes really distressing, really unpleasant. And they're the ones that we really need to be looking out for. Because they're the ones that you can consider to be a clinical problem that needs further intervention and help. I've got a pie chart here on the screen for those who can see it. Before we leave it, it's just to say that one way of thinking about treating Charles-Bonnet syndrome might be to say, well, we want all the hallucinations to go away. But another way would be to shift the people who don't, so who find it very troubling and unpleasant, into a sort of experience that they don't really mind. So it's shifting these people with very distressing hallucinations into the more benign form. And that would be a good treatment. It would help people, even though the hallucinations are still carrying on. So as part of the Macular Society survey, we were very interested to see what were the particular things about the hallucinations that made people find them very unpleasant. And just to whiz through these, one of them was how frequently they occurred. So for those of you that can see the graph on the screen, the people that found them very distressing and unpleasant, they tended to have continuous hallucinations or hourly hallucinations, whereas the ones that had it just occasionally didn't really mind them. And similarly, on the right-hand side, we got how long the hallucinations lasted. So it's only the people that had continuous hallucinations or hallucinations lasting for many hours that found them really unpleasant. Intrusiveness was a really important thing in defining whether you found it unpleasant. So the people with very intrusive hallucinations found them very difficult to live with. And an interesting one on the right-hand side of the screen is that if you didn't know about Charles Bonnet syndrome, when you had your first hallucination, you were much more likely to have a bad outcome. And I'm going to come back to all of these different things when we talk about treatment in the end. So just briefly, how does eye disease cause Charles Bonnet syndrome? And the explanation that we use today comes from the man shown here on the right, if you can see him, David Kogan. He's an ophthalmologist from America. And he described how it was loss of vision from the eyes that led to Charles Bonnet syndrome. And for those of you that can see the picture on the left, I've got a picture of the undersurface of the brain with the eyeballs at the top here. And then we've got the visual pathways that come down to the back of the head, to the back of the brain. It's called the occipital lobe. And when you lose vision from your eye, the nervous signals that go along these pathways stop, and you start to get a hypersensitivity in the back of the brain and spontaneous activation. So what I mean by that is that the brain cells, when they normally would only fire when there was real visual information coming in, they fire of their own accord. That's what we mean by spontaneous activation. And experiments we did just over 20 years ago showed that this was the case in Charles Bonnet syndrome. I've got a slice of a brain here from someone who's experiencing hallucinations in the brain scanner, and they hallucinated faces and colors. And there's some little red blobs here. These are the spontaneous activations of the parts of their brain that are processing normally faces or colors. And that's why this particular person had faces and color hallucinations, because the brain was giving them a signal that actually there's a person outside, there's a face out there in front of you when there's actually nothing there. So we have evidence then that there's this hypersensitivity and spontaneous activation in the people that have Charles Bonnet syndrome. And for those of you who can see this brain slice here, this big red blob is activation in the visual parts of the brain when you're moving your eyes. So this was an experiment that we did with the Macular Society to look for treatments. And it shows that you get this very big hypersensitive activation in someone that is susceptible to Charles Bonnet syndrome. So in other words, not when they're actually hallucinating, but someone that tends to have Charles Bonnet syndrome hallucinations has this hypersensitivity. And the question is, what about the rest of the people? What about the 80% of people with moderate visual loss, or the 40% of people with severe visual loss? What about them? What's going on in their brains? And we know that they have less hypersensitivity. They're less sensitive to visual stimulation. We don't know why there are these two groups, but we do know this is what defines whether you have Charles Bonnet syndrome or not. So the last part of my talk, I'm just going to talk about treatment, and a really important message that I suppose has changed over the years is that there is treatment for Charles Bonnet syndrome. So we used to say, well, it's a normal response of the brain to visual loss, and you don't need to worry because it will get better in 18 months. But that isn't really the right message, because of these third of people which are really finding it distressing, which really need extra help. they need to know that there is a lot of treatment for Charles Bonnet syndrome. And that's really what I've been doing over the last 5 or 6 years, is this large study looking at hallucinations across lots of different conditions. So eye disease, Parkinson's disease, and various different types of dementia. And it's a big study funded by the NHS. And I led the study, but also led the bit on Charles Bonnet syndrome. And the whole idea of the study is called SHAPED, was to come up with some guidelines as to how everyone with visual hallucinations, irrespective of the cause, should be treated. Because as you'll see, there's lots of common factors between all of these different ways of treating eye disease. And I'm just going to go through the treatment flow diagram with you. You don't need to see this to understand what I'm going to say, but for those of you who can see, it's a flow diagram that starts at the top of the page and moves down. And a really important contribution that came from eye disease was that treatment for visual hallucinations and Charles Bonnet syndrome, it starts even before the hallucinations have begun. So the idea here is that if someone is forewarned at the point that they develop their eye condition, that they might have hallucinations, maybe that will prevent the future bad outcomes. And of course, that comes from the Macular Society study that showed that forewarning and information was a good idea. And also as part of the treatment algorithm, we're saying, well, everyone, every routine follow-up that they have with their eye doctor or the high street optometrist should be asked about hallucinations. And the reason for that is that we know you don't own up to having them. We know that a lot of you are worried or concerned about telling people about these hallucinations. And so if we don't know that they're there, you can't really be offered help. So it's up to the clinicians to ask you about them rather than the onus on yourself. Okay, so imagine, so you're all fully aware that hallucinations might happen. And the next thing is the hallucinations actually start. And for those people, everyone should get a sort of general health checkup to make sure you haven't got waterwork problems or other infections that might be causing you to have hallucinations. Everyone should have a brain health review. Now, for those of you that are in the younger age group, this isn't really relevant, but for those of you that are in the older age group, of course, you will have normal memory problems as you get older. But the job here is to make sure that we're not missing people that have got more significant memory problems and just calling them Charles Bonnet syndrome. So it's very uncommon, I hasten to add, but it is an important thing that people should look out for, or at least think about when you first develop your hallucinations. But for Charles Bonnet syndrome, of course, the main thing is about your visual health. And this is about making sure that your vision is as good as it can be, because the more visual signals you can get to the back of your brain, the less Charles Bonnet syndrome you'll have. So that's things like making sure you've got the correct refraction, the best, distance glasses and reading glasses. Low vision aids can help, we know that. And if there's an eye operation or eye treatment that might help you, it's really important that you have that done, because if there was no eye disease, there would be no Charles Bonnet syndrome. In other words, if your vision could be cured, there would be no Charles Bonnet syndrome. Now, the next part of this stage, if you like, of making sure everything's been done for everyone with hallucinations is a medication review. And the culprit medications that you might be on are things like urinary continence medication. So this is medication that you're given if you've got various different forms of urinary incontinence. Atropine eye drops, we know, could be a cause, not so much for macular degeneration, but sometimes glaucoma patients have this. Tricyclic, that's not true, people with eye pain. Old-fashioned antidepressants, tricyclic antidepressants. And now there is some evidence that gastric ulcer medication can make Charles Bonnet syndrome hallucinations worse. And this comes from a very big study of eye clinical populations that found that people with Charles Bonnet syndrome tended to be on a gastric ulcer medication. Now, whether that's a side effect of the medication or some other reason why they're associated, we don't know. But it's worth you knowing that if you're on any of these medications, it might be worth considering alternatives or at least weighing up the pros and cons of the hallucinations versus the problems that you might have if you're not on that particular medication. The next part that everyone should have is a person-centered approach to their hallucinations, and that means tailored to you. So, of course, it depends on what you know or what you want to know and all that sort of thing, but everyone should be given access to more information about Charles Bonnet syndrome. So that's the leaflets and fact sheets. And the Macular Society has one, ESME's Umbrella, which is an awareness campaign specifically for Charles Bonnet syndrome. They have a leaflet. RNIB, even the good old NHS has got its own leaflet on Charles Bonnet syndrome. And I know this because I've helped write them all. And support groups. Again, the Macular Society has got its own patient groups and befriending. There's a new ESME Rooms, which again is specifically for Charles Bonnet syndrome. And I think there's an online version of both of these. So that's the sort of thing everyone should have access to, irrespective of whether they find the Charles Bonnet syndrome troubling or not. And then going back to this idea that shorter hallucinations aren't so troubling, having the ability to stop a hallucination when it occurs, or at least know the types of tricks that some people find helpful, is a good thing. So that's all about general alerting strategies. So that means if you're sitting down in a chair and the hallucinations are troubling you, you can get up and go and do something else, because sort of activating the brain in a non-specific way can stop hallucinations. There's the eye movement strategy that we talked about. There are details in all of the fact sheet leaflets. So that sort of activates the visual parts of your brain and can stop a hallucination in its track, for some people at least. And then there's changing the lighting. So that's getting as much information as possible into the visual parts of your brain. And for some people, it's about making the lights brighter, but for others, it's about reducing the light, because sometimes dazzle and too much light can also trigger Charles Bonnet syndrome hallucinations. So that's the sort of thing that everyone should get. And it's not too difficult. There's no expense involved there. And it should be, everyone should have that available. But then the next step is to look out for those people where the hallucinations have become really distressing and troubling. And this is where we move on to the types of treatment that are going to need a little bit more specialist help and intervention. And one of the approaches is psychological, so talking therapies can help. And again, the Macular Society, of course, have been running its counselling telephone service for a while and have great expertise in this. And there are other sort of talking therapies that are in the pipeline that might help. But that, again, isn't going to work for everyone. And there are various medications that can help Charles Bonnet syndrome. And it's important to know that if nothing else has helped, there are medications out there. And I'm just listing the important ones here. So anti-epilepsy drugs, anti-dementia drugs, both of these, it doesn't mean to say you've got epilepsy or dementia. It just means that these particular drugs, as a sort of added bonus, can help Charles Bonnet syndrome hallucinations. There's certain types of antidepressants, that's they're called SSRIs, that have been shown to help hallucinations, and electrical brain stimulation. Now, this is important because the Macular Society have just funded a study on this, and it involves, I've got a picture here for those of you who can see it. At its very simplest, it involves a battery and two electrodes, one at the front of the head and one at the back, and you're passing a tiny electrical current that's dampening down activity in the back of the brain. And the preliminary findings from the Macular Society studies show that that's enough to reduce the frequency of your hallucinations from maybe many times a day to once or twice a day, or perhaps every other day, or so every few days in a week. And that, as I've said before, might be enough to push you in this from the group that finds the hallucinations really distressing and troubling to the group that finds them rather more benign, and you don't really worry about them. So that's in development, but is a very promising treatment that would be an alternative to the medications and targets specifically that bit of the brain that's causing the hallucinations rather than the medications, which are having general effects across all the brain, and of course would have associated side effects as well. So I'm going to end there to leave some time for questions. I guess I should say that I hope Charles Bonnet would be pleased that his sort of gut feeling that the visual hallucinations of his grandfather were scientifically important. That turns out to be absolutely correct. So thank you for your attention. I'm going to stop sharing my screen if I can, and I'll hand back to Kathy.
Thank you very much indeed. Dominic, that was absolutely brilliant talk. Thank you very much indeed, and really interesting slides. So we have got some questions coming in. Don't forget that you can use the chat function if you want to ask a question now. I've got a few questions that have already come in. One question is that just some sort of nuts and bolts really about the hallucinations themselves. So for example, do they normally change as time goes by? Do they move around, and do they change size? Can they sort of flex and look different at different times? Presumably, the answer is yes to all of those questions. That they change constantly. People don't have the same hallucination over and over again, do they?
Well, it's actually a very profound question. Lots of profound questions there. So the first thing to say would be that we do recognize how they evolve over time. And the typical story is that you start with your simple ones, your lattices and your checkerboards, and then you move on to the more people and objects and things like that. Now, in terms of the size and movement, this is a very difficult question to answer easily, because for the very astute observers, they'll realize that whenever they move their eyes and look in a different place, the hallucination moves with their eye. So unless you realize that, you'll say, oh, it's everywhere and it's moving everywhere. And indeed, if you look at the palm of your hand, you will see a tiny little figure. Whereas if you look at the clouds, you'll see a giant cloud figure, because that's just the way our brains work and adapt and adjust sizes based on distance. So I think probably there is a mixture of people where the hallucinations really just remain fixed in where they're looking, and other ones where they can be looking in the same place and all around them there's movement and changes in size and things. So I think there's a whole spectrum there of different ones, but it really depends on someone getting to know the hallucinations and sort of experimenting with them as they occur to work out whether it's really just where they're looking or whether it's actually generally moving, even if they don't move their eyes.
And this lady's also asked another question, which I think troubles a lot of people, particularly if they have horrible hallucinations, is there any connection between the type of hallucination and the personality of the person having them? Is that possible?
Well, it's so personality, I mean, obviously your past experiences might color a little bit what you hallucinate. That's certainly true. But your personality, now that's a tricky one. I suppose some people, if they're more phlegmatic perhaps, and they don't worry about these things, they're going to be less distressed by it. If they have been anxious in the past about things, they may be more likely to be distressed by it. But the honest answer is I don't really have an answer to that question. There was some very early work on personality types and Charles Bonnet syndrome hallucinations. And I think there's this personality dimension of extroversion and introversion. And I think the introverts are the ones that were more likely to have Charles Bonnet syndrome, but whether they found them more distressing, I don't think that was looked at. So I don't know. It's a very interesting question that we should actually look at about personality and hallucinations.
I've often heard people sort of describe them as the brain trying to make sense of and filling in the gaps. But is that the right way to describe them, do you think?
Yes. So I've given you quite a sort of scientific explanation, but you could say exactly what I said and talk about phantom limbs and about the brain filling in information that's missing because the eye isn't sending it, and the other term is release. So in fact the new way of classifying Charles Bonnet syndrome in the International Classification of Diseases is to call it a visual release hallucination as well. So all of these things, it's the same idea, but just using different terms. So it's absolutely right to say filling in the gaps.
Another question that has come up is about whether Charles Bonnet hallucinations are ever accompanied by sound. And obviously quite a lot of people in an older age group will have hearing loss or maybe have a condition like tinnitus. What's the relationship between those conditions as well, do you think?
Well, there is an auditory version of Charles Bonnet syndrome, a hearing version of Charles Bonnet syndrome, and that occurs in people that have got hearing impairment. So the typical hallucinations there, they're like visual Charles-Bonnet syndrome. They tend to be a bit bizarre. So you get heavenly choirs singing old time tunes. So there's a lot of musical Charles Bonnet auditory hallucinations. Now, is it possible to have both hearing loss and the auditory version of Charles Bonnet syndrome and visual loss and the visual version? The answer is yes. So you can have it, but it's quite unusual. And most of the people, I think, on the call today and people attending eye clinics will have silent visual hallucinations. And what we do say is that if there's voices or other auditory phenomena that go on, then it's important that we look for other things. And that could be hearing loss, or it could be other types of conditions that would be occurring alongside the eye disease. Because if you've got eye disease, it doesn't protect you from having other problems as well. So it's important that we recognize that somebody looks for other things that might be going on if you have voices or auditory hallucinations as well as visions.
Okay, that's really interesting. So another question has come in now about the lack of awareness of Charles Bonnet syndrome in other medical professionals. And I know that Judith, who I think may be joining us tonight from Esme's Umbrella, I think set up her campaign because of her own family experience of of going through this for a very long time before anybody recognised what it was. Is this common that actually people don't know, other medical professionals really don't know very much about Charles Bonnet syndrome?
Yes, I think you could, across the board really, from eye care professionals, so that's optometrists and ophthalmologists, to your GPs and your even psychiatrists and geriatricians. The knowledge of it is not great. And for those people that know about, have heard of it at least, they won't have necessarily the update understanding. And part of the problem is that many people that have heard of it will think of it as something that you don't need to worry about and it goes away and all that kind of stuff. So they won't know the kind of the most up-to-date information. And I think Esme's Umbrella, Macular Society, there's, part of the work that we do is to raise awareness amongst all these other professionals. And it is very difficult. As you know, Kathy, we've been doing it for many years, and you can have a lot of interest and it very soon gets forgotten. I don't know why, but things do seem to get forgotten. And so we need to have some kind of sea change in the way the access to information and the way it's taught and how people find out about it to keep people abreast of developments, I think.
Somebody else has said that her mother has been diagnosed, has been given lorazepam, which sounds as if it's an anti-anxiety drug. That is the kind of medical intervention, drug intervention that you're talking about, and that would be a reasonable thing to.
Well, that's a sort of calming medication that's not specific for Charles Bonnet syndrome, and of course, we don't know the exact circumstances of that, so it's not unreasonable. And if it helped, then that's a great thing. It actually is. It also, that class of drugs also works as a sort of anti-epilepsy drug as well. So it may be working in the way that I've described, but it's not one of the obvious ones that is given as a first treatment for Charles Bonnet syndrome, and it's certainly not one that causes Charles Bonnet syndrome.
And I guess this lack of awareness, particularly amongst perhaps GPs, means that it's quite difficult to get them to engage in a treatment idea for something like visual hallucinations in some cases.
Yes. I think one of the problems we have at the moment is we don't really know who should be treating Charles Bonnet syndrome. And the reality is that there's so many people with it that you can't have, not everyone can see a super specialist. I think everyone needs to know, or at least have access to the type of the baseline treatment that I described that everyone should have, this sort of general checkup and all that sort of stuff. Now that probably might be the GP, because if they're looking at your medication and your general health, that would be an obvious person. But it could even be the high street optometrist, and anyone could do that sort of thing as long as they know about it and are confident to give you that sort of advice. And I think at the moment, one of the things is everyone being given signposted to one of these leaflets or something that tells them what to do next, because the clinicians might not necessarily know themselves.
We spent a lot of time persuading actually the Royal College of Ophthalmologists to change their guidance to be explicit and say that eye doctors should talk to patients about Charles Bonnet syndrome, because I think the school of thought had been a bit sort of paternalistic and say, well, not everybody will get it, and if we tell people, it'll frighten them, and they might never get it, and will have frightened people unnecessarily. And our view was that actually it's much better to perhaps make people a little bit more wary than they would otherwise be, but it's better that than leave so many people really very distressed when they get it out of the blue and have no idea what it is. I'm still not sure how often it happens that ophthalmologists and eye clinics do talk to people about it. I think it's still a problem.
Yes, I think, well, there's the initial visit that you have when you've been told about your eye disease, and there's lots of things to talk about, and I imagine it's not going to be high on the priority list, but it's really the follow-up ones when you maybe see the eye clinic liaison nurse, the ECLO, or some other kind. Or often it's the visual rehabilitation officers that you have more time to talk to, or the if you go to a low vision clinic or visual aids. They're the sorts of people that equally need to know about this, because you're more likely to have the conversations with them. But you're absolutely right. The ophthalmologists are supposed to mention it amongst all of the other things that might happen. But of course, that's specifically for macular degeneration. It could equally well be for glaucoma, or for for the younger adults. It'll be some of the genetic diseases and that sort of thing, where in theory they should be told about it as well.
There's a lot of worry about overloading patients with information, I think, isn't there, as well? So sort of, as you say, signposting to the leaflets and where people can get further information at the right time. And I think a question about how, if you're having difficulty getting your GP to take it seriously, then go in with one of our leaflets, take it to the GP and say, do you know about this? I think is one thing that people can do. Another question about cataracts. This question, her mum has got Charles Bonnet. She also has macular degeneration and glaucoma, and now has a cataract as well. And the question is, would having the cataract removed be any help to the Charles Bonnet?
Well, it could, if the removal of the cataract improved vision, the answer would be yes. But they're always very difficult, benefits and risks type questions, and it could well be that the macular degeneration underneath the cataract won't actually improve vision, and there's extra risks, etc., going on. So it's a discussion certainly to have with the eye doctor. But the simple answer is yes, it could be that the cataract removal would improve vision enough to stop the Charles Bonnet syndrome.
Can we talk a bit more about the brain stimulation research then? Why would that work?
So if you remember, we talked about hypersensitivity, and the brain stimulation. One end of one wire stimulates, and the other wire dampens down. So we put the dampening down one over the visual parts of your brain to stop this hypersensitivity. And so the idea is if you can improve that, then you won't have the hallucinations anymore. And that seems to be what this trial has shown. And Kat De Silva Morgan presented it at your the London conference, the virtual conference, but it was a carefully designed study that had a pretend stimulation as well. So it had both the real stimulation and the pretend one. And we showed that actually it's not a sort of placebo effect that you're hoping that the treatment's going to work. It's a real additional benefit of the real brain stimulation.
So that was quite a small study, wasn't it? Almost a sort of pilot study. What could happen now? What would you like to do more? What would you like to do more research on this, on perhaps in a bigger study or something like that? Where would it go next, naturally?
Well, I think there's more that needs to be learned about how long the effects last, how long the benefit lasts for, how often you need to do it, and then developing the device into something that really could be used at home. So the ideal scenario is that if you've got Charles Bonnet syndrome, you buy, or you're given this very cheap piece of equipment, and you're taught how to put it on yourself. And when your hallucinations are bad, you give yourself a 20-minute stimulation of this, and then maybe you need to do it once a week or something, and that will be enough to keep you well, even if you've got hallucinations that go on for many years. So that's what we're sort of aiming for, is developing the technique into something that could be used like that. For it to be licensed by the NHS, there need to be certain steps that we need, evidence that we need to provide, and so that might need a slightly larger trial than we've had before. But so there are lots of things that still need to be done. But as it stands, there is this treatment that we know works. And I ran part of this study in London with people that had continuous hallucinations. So we were stimulating them while they were hallucinating, and 5 out of 6 of them found some positive benefit that lasted at least a few days, or in some cases even a few weeks, with the hallucinations sort of shrinking down and allowing them to use their remaining vision better. So there is something available today that we can do in a sort of research setting, but to make it available for everyone and to broaden it out, we need to do some more research to prove its effectiveness and before basically that you can be advised as the treatment of choice for Charles Bonnet.
It's great. It's great. It's a very interesting study. We're running out of time, so I'm just going to whiz through a few more questions there. So one question about a mother at the age of 98. She is absolutely convinced that the people she sees are real. Now the question says she doesn't think her mother has any dementia, but her mother is absolutely convinced that these people are real. I guess sometimes if the images are so much more vivid than what people can actually see, that must be a very common belief. Is that right?
Yes, I mean, I suppose it's a difficult one because you can be it can be so realistic that you believe it's real, but the problems arise when you act as if it is real. So phoning the police, phoning the ambulances, phoning the fire service and this kind of stuff is a sort of clue that you don't really understand it's a hallucination. And that usually suggests that there's something else going on as well. And that's where you probably need to have someone ruling out other possible causes of the Charles Bonnet syndrome. But being so realistic that's a firm belief that something is there is fine. That's fine in itself. But it's when you start to behave in these other ways that I think people should be more concerned that this goes beyond what we would normally expect for Charles Bonnet syndrome. So
something that needs investigating a bit further.
Yes.
Than the sounds of things. Another question. This is a very common problem, I think, in one way or the other, particularly when people are out and about. It's very limiting in terms of mobility. So somebody here who has trouble seeing an empty road in front of them when in fact there is traffic. And I can remember speaking to somebody once who in the car would hallucinate a brick wall suddenly in front of the car. Obviously he wasn't driving the car, but as a passenger. And that's very alarming, isn't it? It can be very limiting when you have that kind of hallucination where it's disorientating, particularly seeing an empty road when actually there's traffic. Very dangerous.
Yes. So it's not uncommon to have people where the real visual world is replaced by the hallucination, and you sort of get a bit lost as to where you actually are. And it can express itself as people seeing a cliff in front of them, for example, or as you've described, brick walls and things like that. I always tell the story of a very unfortunate story of a gentleman who used to hallucinate brick walls, and the one time it wasn't a hallucination, he walked into the real brick wall and broke his nose and had quite a serious injury. So you can imagine you will lose confidence if you can't really tell the difference between the real world and the hallucinated world. And it is absolutely an important consequence. And one of the factors that made the Charles Bonnet syndrome to be more unpleasant and more difficult to deal with was this intrusiveness and getting in the way of normal vision, or confusing the hallucinations with real things.
What you mentioned that there's a small percentage of people who actually actively enjoy their hallucinations, and that must be hard to imagine, really. What is it? Why do they enjoy them?
Well, like I said, because in the context of your failing vision, you can't see the world around you. It's all blurred and you need your magnifiers and everything, but your hallucination is crystal clear and you can see fantastic detail. And I suppose that is comforting in some ways. Again, it would be a personality thing, won't it be, that not everyone will find that amusing or comforting, but some people do. And unfortunately, Lulin, so the original description Llewellyn, the grandfather of Charles Bonnet, he did enjoy them and relished telling the stories about them. And that sort of idea that they're pleasant has got into the sort of clinical mindset. And one of the other reasons why people say if you've got Charles Bonnet syndrome, it doesn't matter, because of this idea that, well, everyone might enjoy them. But we know that's really a very small percentage of people that actually enjoy them. And I very occasionally have people that ask for them not to go away, that they don't want the hallucinations to go away when they start treatment. But the majority of people who are looking for help, they would love the hallucinations to go away.
I did remember speaking to somebody once who, whenever he went out for a ride in the car with his son driving, in uncertain light conditions, he would hallucinate huge vistas in the sky, pink landscapes and castles, and he thoroughly enjoyed them. He thought they were very entertaining and enjoyed the experience.
Yes, so the car journeys is a very common one. The passenger in the car has the hallucinations. It can sometimes be a building right in front of the car, very scary, as you said, architectural things flashing by. It's a whole range of things. And we still don't know why. What is it about driving in the car that brings them on? Now, it may be something to do with your sort of spared peripheral vision that's being stimulated by things whooshing past. We just don't know. But it's a very common story that people being driven have hallucinations at the time.
So then for the future, brain stimulation is a particularly interesting area for you. Yeah. Is there anything else that's going on that we should be looking out for?
Well, I think one of the things on my agenda is at the moment, so Charles Bonnet syndrome isn't considered part of ophthalmological treatment. So if you've got retinitis pigmentosa, if you've got macular degeneration, all eye doctors are funded, if you like. The NHS funds eye care in that way, but they don't fund Charles Bonnet syndrome. So there are very few places where you can go. And to come to my clinic, for example, we need to go through a whole process of individual funding for, to come to the specialist clinic. So that has to change. There has to be some way in which Charles Bonnet syndrome is adopted in the NHS pathway, so that everyone across the country can see someone that at least knows a little bit about it, or can do the more second level specialist sort of care. So that's something that I think really needs, that's a sort of NHS policy type change that needs to occur alongside the treatment side.
Well, that's maybe something that we ought to be focusing on as well then. We sadly run out of time, Dominic. We're coming to 8 o'clock. But I am so incredibly grateful to you for giving up your evening for us. Thank you to everybody who's joined us this evening. If you came in halfway through, or you'd like to see it all again, or you know somebody else who you think ought to see this, then we will be posting this session up on our website in the next day or two. So you will be able to pass on the link and make sure that anybody who needs to see it will see it. Our next virtual clinic is in a month's time at 7 p.m. on November the 10th. We'll have two guests on that occasion. Declan Flanagan, Mr. Declan Flanagan, who is the consultant ophthalmic surgeon and the medical director of Moorfields Eye Hospital, and our own Colin Daniels, the manager of our Working Age and Young People Services. And they'll be talking about the Certificate of Visual Impairment, the CVI, what it is, why we have it, and why it's
really quiet. Oh, good.
That will be
November
the 10th at 7 p.m. We're hearing somebody over the top of that. But anyway, thank you very much indeed, Dominic, again for joining us, giving up your time. We are so grateful to you. Thank you to everybody who joined this evening. I do hope it was enjoyable and interesting, and please do join us for the next one. Thank you very much indeed, everyone. Good night.